You.
I'm great. How are you?
I'm
Uh,
so good. Thank you so much for joining us today.
so we're good. Okay.
You
Right.
can you can see and hear me clearly.
Yes, I can. Absolutely.
Awesome, awesome. So just for the sake of time, I know we will get some people that would keep rolling in, but I definitely want to be able to maximize the hour that we have with you tonight. And I'll just start off by introducing myself, and then I can read your bio, and then you can give us any additional thoughts that's not covered here that you want to share with everyone that will be tuning in. Okay?
Okay, wonderful, wonderful. Thank you.
Awesome. So my name is Tamara Lumsden. For everyone that's joining, I am a coordinator for campus life and student engagement at Nova Southeastern University, and I serve on the regional leadership team for NACA South as the inclusivity coordinator. Each month we have these competencies that we tackle, and specifically this month it's health, and we wanted to hone in on women's health. So we have invited Dr. Ellen Wood to have conversations about some of the myths that exist around women's health. And Dr. Ellen Wood is a certified obstetrics and gynecology, and in the subspecialty of reproductive endocrinology and infertility. Whew. Um,
Wonderful.
Yes, Dr. Wood is a member of the American Society of Reproductive Medicine and a distinguished fellow in the American College of Osteopathic Obstetricians and Gynecologists. She is a voluntary assistant professor at the University of Miami School of Medicine and Florida International University School of Medicine. She has also served on the clinical board examiner for the American College of Osteopathic Obstetricians and Gynecologists since 2011. Um, I know you do a lot of mentor work. That's actually how I got connected with you. One of my students was shadowing you over the summer, and she was so excited about learning from you. I thought it was perfect to get connected to bring you into the space. But I didn't know if you wanted to add on anything additional, because I know I didn't cover half of the things and the accomplishments that you've done in your position and in your career.
Yeah. Well, I'm just gonna kind of summarize for you guys basically what I do. Okay. And a little bit just kind of about my about my training. I'm thrilled with the 6 embryos. There's something that came through the feed.
Yes.
So my name is Dr. Ellen Wood. Okay. I'm a part of IVFMD. Okay. And we are a fertility practice. So basically what we do is we help couples have children, okay? Whether are heterosexual couples, same-sex couples, single mother couples, single father couples, we help people have babies. And so what we are is we're 12 and we're in 6 offices. We're spread all over basically the bottom half of the state of Florida. Our mainstay is in vitro fertilization. So we make basically test tube babies, but we help patients with recurrent miscarriage or patients with complex gynecological problems. It's basically women's health, even though a lot of our business does have to do with male factor infertility. So we have offices in South Miami, in Cooper City. I'm one of the Cooper City doctors, which is close to Nova. And then we have an office in Boca. We have an office in Jupiter. We have an office in Vieira. And on the West Coast, we're over in Naples. So we are spread out all over the state. And basically, women's health is our thing, and making babies. So it is something that I'm passionate about, and I got the issues that we wanted to discuss tonight, and hopefully other patients or other questions from your followers that I'd be more than happy to answer for you. But thank you so much for inviting me. Hopefully this will be educational for everyone who's listening.
Absolutely. So I think we should just jump right in, if you're okay with that. We've accumulated a list of myths that exist around women's health. We try to keep it as well-rounded, but still tackling your specialty. So one of the myths that I'm sure a lot of women have heard is that bras can cause breast cancer. Is that true? Is it not?
Oh. This is one of the craziest thing I ever heard. And it comes from basically fake news back in the mid-90s. Okay. So this is something, I mean, it's kind of like, you can't swim when you're pregnant. I mean, like, I mean, this is a complete myth. So in medicine, it's really interesting. So a lot of associations, okay? So when you look at what are risk factors for breast cancer, okay? So risk factors for breast cancer are basically obesity is one of them, okay?
Mm-hmm.
You know, if you are heavier set, you have a tendency to have larger breasts. And most women who have larger breasts have a tendency to wear bras. I mean, and sometimes women who are tinier, who are thinner, you know, may not need to wear a bra, you know, for support and for comfort. So this study that even proposed this was not based on really anything. However, when you do look at kind of a demographic and you say, well, what's the risk factor for breast cancer? And, you know, there are significant risk factors for breast cancer, and one of those is being heavier. Why? Fat produces extra estrogen. Okay.
Mm-hmm.
And you're exposed to extra estrogen throughout your life, okay, and you have a predisposition towards breast cancer, that many of breast cancers, as we know, there's receptors that go along with breast cancer. There's estrogen receptor cancers, progesterone receptor cancers, you know, receptor negative. I mean, however, breast cancers are very, very specific. So if you have an estrogen receptive cancer and you're heavier set and you have more estrogen in your body, you know, this could be an association, but it's not the fact that you are a bra. It's the fact that you were heavier set, and your body produced extra estrogen. I mean, and this, you know, this goes along with kind of, you know, a multitude of different risk factors as far as breast cancer. But that's the one that really, when you see, like, why would that be associated? You're just kind of, I mean, I kind of think to myself, I'm like, I think that it makes absolutely no sense.
Right.
But it's kind of like, you know, there's studies about, you know, alcohol. Lots of people smoke when they drink. So, I mean, you know, and so you can't just weed out the people that drink and say they're, you know, drinkers get lung cancer. Well, a lot of people, when they drink, they smoke. So, I mean, there's things that piggyback on each other. And so a lot of data is very, very, very hard to get unless you're working with animals, okay? So if you're working with animals and you're putting little bras on mice, okay? I mean, and whether, you know, binding up the little mouse titties, you know, are going to increase the risk of a mouse getting cancer. You know, it's very hard to find a homogeneous word. So I think that when, you know, that was analyzed, there's confounding factors that were not taken out of play.
Got it.
That's just ridiculous.
Okay, so myth number 1 is in fact a myth. Got it. All right, so myth number 2, you can't get heart disease until you're older, and heart disease mostly affects men anyway.
Well, heart disease is the #1 killer of women in the world.
Wow. Okay.
1 in 5 women have heart disease. I mean, no, it's crazy. I mean, my mother had a heart attack. I think she's 78 now, and this is probably about 12 years ago. So my mother had a heart attack at probably age 66. Atypical symptoms. I mean, it wasn't the classic crushing chest pain that men feel. It was more like GI distress. It was more like some short of breath. And so heart disease in women, #1, goes undiagnosed because they don't have the typical symptoms that men have. Then one, my ex-husband's mother, okay, and this is a true story, okay. Women are protected, okay, by hormones. And the reason we're protected by hormones is because they make our blood vessels stretchier, okay? So what is a heart attack? Heart attack is buildup of plaque in your arteries, okay? And the plaque gets hardened, okay, and your blood vessels get narrower and narrower and narrower. Well, if your blood vessels are a little more pliable, even though they have extra plaque, and they're kept pliable by a woman's hormones that her ovaries naturally produce, okay, it's more forgiving. So you can have cardiovascular disease, but you don't really, you know, feel the effects of it, because even though your artery is narrowed, it's still a little stretchier. Guys don't have the estrogens that make your artery stretchier. So if you take out a woman's estrogen and you leave her in menopause after a hysterectomy, okay, you just depleted all that stretchiness. And if you have heart disease, so my ex-mother-in-law, she was a smoker, okay, and at 44, okay, she needed a hysterectomy. They took out, at the time, you know, this was like 35, 40 years ago, they took out your uterus, they took out your ovaries, okay. She had a hysterectomy, okay, took out her ovaries, continued to smoke. Again, you know, people still back then didn't know how dangerous it was.
Right.
At age 44, on Thanksgiving weekend, she basically had a massive heart attack.
Wow.
At 44 years old. Okay, but this was 6 months after the hysterectomy. She had the symptoms, they took her to the hospital, she was saved. Okay, she's now almost 80. Subsequently, she has had 2 more heart attacks. But she had risk factors. So besides having hysterectomy and losing her estrogen, she also was a smoker and she also had cholesterol. So, you know, whereas these factors were protective until when she was with estrogen, they were no longer protective after estrogen. So this is where when women go into menopause, they're lacking estrogen. They don't have this hormone that protects them, the arteries stretchy. And so we will start to see more and more of this heart disease manifest.
Got it.
You just, and it just, the hormones keep us protected. You know, you don't hear of the woman dropping dead at age 40, like you hear the guy dropping dead of, you know, coronary artery disease. And the reason the guys drop dead of coronary artery disease when they're young is because they haven't developed the collateral circulation. So when the big artery gets clogged, you know, and down, they're dead. As you get older into your 50s and 60s and 70s, even if you have a heart attack, because you have vessels surrounding the heart that are just little teeny blood vessels that are keeping the heart, you know, with blood supply. You know, the big event, sometimes, you know, you're able to survive it because the heart can still get blood. But, you know, when we're talking hormones in women, it is dramatic, the difference in health when you have them and when you don't have those hormones. And again, there's risks, benefits, you know, to everything, is even, you know, hormone risks and benefits. But, you know, and this is why, you know, we don't really focus in on, you know, heart disease in women, even though it is 1 in 5 women will die of heart disease, where, you know, 1 in 8 get breast cancer, 1 in 5 will die of heart disease.
Right.
Again, so it's the lack of estrogen, the misperception, and you know, the symptoms that a woman over the age of 50 they're atypical. Even when they go into the ER, I mean, I would have to say my mother complained. She was riding her bike across the bridge, and she just, I'm just not feeling that good. I'm kind of fatigued. You know, the stomach kind of hurts. And it was her husband who said, I think you need to get checked out. Like, this is just doesn't sound right. And she went to the ER and she flipped her T-wave. She needed stents. I think they put in 2 stents or something. I mean, she had, you know, narrowing of arteries. I mean, it was just like, are you kidding me? But the symptoms were clearly not classic, like we would think about with a man who would come with the ER with that crushing chest. So I think they're the two issues, but really just not thought of. I mean, we just,
Right.
you know, most, even physicians, we don't go there, because it's not even in some, you know, the forefront of our minds.
Got it. So 1 in 5 women are at risk of heart disease, and I just want to make sure that I'm understanding everyone else's understanding.
And then 1 in 5 women.
And then you are at a higher risk of getting it when you're older, because after menopause, and if you've had a hysterectomy, you have taken out some of the hormones that do help your organs be more pliable, is what you said, to navigate with the plaque buildup. Am I learning?
Yep. You're learning.
Okay.
Yep.
Awesome. Okay.
Yep.
So myth number 3, postpartum depression is not a real thing.
It is so real. It's scary.
Mm-hmm.
And I think, I mean, I'm an OBGYN. So, I mean, again, we work in this world. So, you know, so we see this. But when you are pregnant, you have more hormones going on in your body than you ever will any other time in your life. Okay. And these keep your mood elevated. These keep your body relaxed. I mean, everything is relaxed, ready for this pregnancy. And when you have this dramatic drop in hormones. I mean, this is very difficult to navigate. Thank God I was so busy with, going back to work and, the baby. I mean, I was overwhelmed when I had my children. I mean, and the worst thing that I suffered was like baldness. Like, I mean, literally this patch of hair right here, bald twice. Like,
oh, wow.
Literally completely bald. I mean, I remember taking a picture when I was an attending in Hahnemann after I finished my fellowship, and it was I was 3-4 months postpartum, and I had all these little hairs sticking up all over my head because they were just growing back after the hair had fallen out. So literally, you deliver your baby, your hormone levels plummet, your hair just falls, but also hormones manage mood.
Right.
And there are protocols that OBGYNs have that are at the postpartum visit that are on the intake. Are you feeling this? Are you feeling that? Are you feeling this? And every woman is screened for postpartum depression because there are medications that can get them through this period of time. And they don't want to admit it. I mean, their husband's home for a couple of weeks and then they're left with the baby. They're overwhelmed. They're alone. And you can't navigate that without help, number one, and unless it's identified. And this is why crazy situations happen. But it's still, it's so much about hormones. It's insane that dramatic this effect can be on a woman's body. So postpartum depression is absolutely real. And I think the vast majority of OBGYNs are very well aware of it. And they have the screening mechanisms at that postpartum visit in order to, and the tools to say, is this woman at risk? Is she not at risk? If she doesn't answer the questions right in the questionnaire, all right, let's talk about this before you leave. Do you think you need something to kind of get you through this time until your hormones regulate again?
Yes.
So.
And, a lot of conversation around postpartum is probably not being had because a lot of women feel guilty about how they feel during that section in their lives, right?
I do. I mean, I think there's like, and again, this is women in general, okay? We need to be super born. Like, we need to have it all. Like, we need to have babies. We need to get back to work. We need to raise the baby. We need to prep dinner. Like, we need to do it all. Like, we should be able to have it all. And for some women, I mean, a lot, it's kind of like, no, I have to admit, I need help. Like, I can't do this alone. Like, I need help. I am not Superwoman.
Right.
And if you push yourself to that, and there's many patients that, I mean, I see fertility patients. So my patients are type A, and they're like, I should be able to, do this and do this and do this. And why does my body failing me? And why is my body doing this for me? And you don't want to admit this, that look, I can't do it all, and I need. But I do think that the majority of OBGYNs, it's been really brought to our attention, and we do have the screening tools in place in order to try and identify and help patients. But no, it's real. I mean, these hormone fluctuations. We use a drug in order to help patients get pregnant called Clomid. Amazing. Okay, that this one little pill that we use for 5 days. Okay, and what it does, it tricks your brain into thinking your estrogen levels are low because it blocks the estrogen receptor. Okay, you have, and 90% of patients don't have side effects, but 10% do. And when you'll sit in front of a couple and you have a husband and the wife, and like, oh, the OBGYN put my wife on this drug and she turned into a crazy person. Like she was, she was out of her mind. And you're like, Clomid? I mean, it's this little $10 pill to help somebody ovulate. And in some women, because it blocks that estrogen receptor, okay? It's like Dr. Jekyll and Mr. Hyde.
Wow.
My wife turned into. And it's just this little pill we used to get them to ovulate. And because it blocks that estrogen receptor, which is so essential for mood, it's amazing. It always blows my mind when you hear this, because you hear it over and over and over again, the mood altering effects when you block a woman's estrogen receptors. So it just goes to show the importance of these hormones play in the sense of well-being, that you have.
So this is not a myth, but just a follow-up question for estrogen and how it affects our mood. Does that have a part to play in when women are typically PMSing
Oh
and
yeah.
having, okay,
Oh
so
yeah.
that's what's happening to us when we're about to
Well,
start our cycle and things like that?
but unless you have a balance
Mm,
between your estrogen and your progesterone, okay, your mood is altered. So, PMS is somebody who's not achieving the adequate progesterone levels in the
mm,
second half of their menstrual cycle because of a weak ovulation, and weak ovulation comes with age. So this is why a lot of patients will develop, more of a PMS type of symptoms as they age because their hormone levels are weaker. And
mhm.
so typically sometimes if patients are not trying to, we will actually supplement them in the second half of their menstrual cycle with extra natural progesterone, okay, that will keep them more even.
Got it. Okay, that it's all connected. That
Yeah,
makes so much
no,
sense.
it's the hormones and female mood is such a balance.
Mm-hmm.
There's so many different hormonal methods to do it. There's synthetic hormones, and then there's natural hormones, and there's drops and there's creams, and everyone has to find the balance for her. And there's multiple doctors out there. I mean, I don't do bioidentical hormones, but again, I've trained in them, and these bioidentical hormones, are used, by women that are very in tune to their bodies, and they know exactly what that makes them even, because lack of these really 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 important hormones are going to sometimes put you off the deep end. I mean,
Wow. Okay. So myth number 4. I'm sure we've all heard this one as well. Cranberry juice cures UTIs.
okay, it does. Okay, so what's a UTI? Okay, what is a UTI? A UTI is when you have bacteria living in your bladder. Okay, like
Right.
an infection.
Mm-hmm.
Bacteria cause infection. Well, cranberry doesn't kill an infection.
Mm-hmm.
I mean, however, antibiotics cure infection. Now,
Right.
cranberry juice can make changes to the pH in your urine,
Mm.
makes the environment the bacteria are living in less friendly to the bacteria. So they
Okay.
don't want to live there anymore. It doesn't kill them.
Right.
It makes them not want to live there. And it can also change the kind of the line bladder where the bacteria are hanging out and not allow the bacteria to stick as well along the wall of the uterus. Okay,
Got it.
so it's not going to kill bacteria. Antibiotics kill bacteria.
Mm-hmm.
However, it's going to make the home that the bacteria is living in, a little less friendly. So
Got it.
they may not want to hang out there as much. So
Got
where
it.
it's not a cure, it can help the antibiotic work, because if the bacteria is like growing, proliferating, it's like, well, we can't cure because the lining of the bladder isn't allowed to stick on the wall, and the pH is kind of making it not. So the bacteria may not continue to proliferate as quickly, but really, antibiotics, bacterial infection.
Got it. So essentially, so if we are drinking the cranberry juice, it's not killing the bacteria. You still have to get the antibiotics, but maybe one could argue that it's making it more of a less, what am I trying to say? So that it's not as bad. It helps the process.
Bacteria to live.
Okay.
And
Okay.
it's not in every woman, but again, there's a lot out there about cranberry, but cranberry, you have an UTI, cranberry juice is not going to kill it. Okay,
You still
but
need antibiotics.
you still need antibiotics.
Got it. Okay. All right. So this one says if you have PCOS, you are infertile. So I guess unpacking what PCOS is and what it stands for, and then why someone would think this is true or not true.
Yeah, this is my world. Okay, this is my everyday. Okay,
Mm-hmm.
so I actually am thrilled when I see a patient with PCOS. Okay, thrilled. Now, what is PCOS? So PCOS stands for polycystic ovarian syndrome. Okay, so there are 3 things that you need to diagnose polycystic ovarian syndrome. Okay, so one, you need to have lots of little follicles on your ovaries on ultrasound. Okay, so you have to have over 12 to 15 follicles on each ovary. So the follicles are going to be little dots that you see in the ovary. Okay, one of the criteria. One of the second criteria is you need to have irregular menstrual cycles. Okay, and then the third criteria is you need to have what we call hyperandrogenism. Okay, or evidence of higher testosterone levels, which can manifest in blood, which can manifest by acne, chin hair, hair loss, chest hair. Okay, so these are signs that a woman has extra testosterone. So when you're diagnosed with polycystic ovarian syndrome, you need to have 2 out of 3. Okay, so if you have ovaries that look normal, okay, and irregular cycles, normal testosterone levels, that's not PCOS. You don't have it. You have to have 2 out of 3. So you get cycles and high testosterone and ovaries, okay, yeah, then you have the diagnosis. Okay, but in general, polycystic ovaries means your ovaries have more eggs than most people. Okay, so I'll take that any day. Give me somebody with more eggs any day. Okay, can help you have a baby.
Okay.
Somebody in, premature menopause who has no eggs left, and this is something that I can't get blood from a stone. Your ovaries don't have eggs. I have a very difficult time helping you get pregnant. We can use donor egg, we can use someone else's egg, but if you have eggs, I can work with this.
Right.
Now, this is the problem with polycystic ovarian patients, okay, and why the infertility goes in there. So what do you need to get pregnant? You need sperm. You need open fallopian tubes, okay, away from find the egg, and then you need eggs, okay? Eggs, ovary, okay? However, an egg needs to grow, mature, and pop in order to get fertilized. So if the eggs are just sitting there in the ovary and nobody is growing, maturing, how do you get pregnant? So there's a multitude of different ways to try and get the ovary to respond to the natural signals your brain sends out to tell these eggs to grow. Now, when you have a lot of eggs in the ovary, okay, your brain, it's just talking to your ovary, hey, let's ovulate, hey, let's ovulate, hey, let's ovulate. This is kind of like talking to a crowd without a microphone. Ovary, hear anything? I don't hear anything. No. Got it, okay? And nobody, and maybe every once in a while someone in the front row might say, oh, we're supposed to do something this month. But in general, you have so many eggs in your ovary, okay? The brain is sending out these signals completely being ignored by the ovary because it's a crowd down there. Okay? In the majority of cases that I do, I give the brain a microphone. I give them a fertility medicine that will ramp up the brain signals, and then the brain will start to shout at the ovary, and one of these little follicles down will pay attention.
Got it.
However, that's what the fertility doctor does. Okay? But what can a patient with PCOS who doesn't want to come to a fertility doctor do?
Yeah.
So there are other things that will blunt the signals that the brain sends out. Number one, high insulin levels. High insulin levels, okay, are something that will basically cause the ovary not to respond. High insulin levels, predisposition towards diabetes. What causes high insulin? Okay, carbohydrates, simple sugars, sweets, okay, white rice, potatoes, pasta, white flour. All of these things will cause insulin levels to spike. And basically what insulin acts like is a soldier that surrounds the ovary. So if you have higher levels of insulin, which is predisposing you to diabetes, you basically have an army around your ovary. And signals are coming out, our army's now talking, so nobody's hearing. So when a patient is, say, pre-diabetic, diabetic, overweight, carries extra insulin and is running a background level insulin that's high because of a poor diet, okay, ovary's not going to work as well. We'll have patients that will eliminate white flours, carbohydrates, processed foods. They'll eliminate these things from their diet. Bam, they get pregnant. It's like wow, okay? Because the army, went home, they retreated. So insulin is one thing. And the other thing is excessive weight. And unfortunately, when patients have higher insulin levels will cause you to store fat because your body needs to burn it. Okay, insulin says we're good. We have enough. Okay, you eat something, it goes right to fat.
Mm-hmm.
As we talked about with the breast cancer patient, produces extra estrogen. Okay, when your body has enough estrogen, the brain says, we good. Because where does the body get estrogen from? The ovary.
Mm-hmm.
But when around extra estrogen, brain's like, we don't really need to ask the ovary for estrogen because we got enough. So excessive weight, okay, will also cause the signals now not to even come out right. So now it's not sending out signals because the extra weight is causing extra estrogen, and the brain's like, we're good. Ovary doesn't need to make us estrogen. So it's a very, very, very vicious circle. But as long as that woman has eggs, okay, again, we can use, first we start with fertility pills, and then we can always use fertility injections to get her body to ovulate. So fertility pills and fertility injections, which will work, 99.9% of the time, will work. However, before we initiate this as a fertility specialist, okay, we look at lifestyle because there are so many patients. We have lifestyle coaches that are in our, and literally we send them to the lifestyle coach. The lifestyle coach reviews their diet, reviews their exercise regimen, checks their insulin levels, and says, look, if we can decrease your body fat by 5%, you might not have to pay $20,000 for it.
Okay.
And trust me, our one of our lifestyle coaches in Miami, she just has like a billboard of pictures of babies, and she's like, they didn't have to go to you guys, we sent them to her to prepare them for us, and then we were working with her just on these lifestyle changes. Okay, bam, they got pregnant by accident. They're like, I'm pregnant. How did I get pregnant? It's like, well, you changed this, you changed that. Our lifestyle coach helped you out. So it's PCOS is definitely not something that said, oh, I'm never going to have a baby. There's so many things that begin with lifestyle, and if that's not successful, we have the amazing medications and treatments in order to help those patients. So yeah, I mean, even though PCOS patients are sometimes a challenge, they're never something that's, I'm like, we can help you. No worries. I have no worries that these people will leave our practice at some point with a baby. So
I really love the analogy of how you broke that down with the ovaries, the insulin becoming this shield around it, the brain, all of those things play a huge part in that whole PCOS. So one of the follow-up questions that I have for you regarding that is, so let's say they do make the lifestyle changes and now they are able to get pregnant. Is PCOS something that is attached to them for forever? Or does it leave and come back, like based on your lifestyle?
Yeah, well, unfortunately, PCOS, there's a genetic predisposition towards it. Okay, so it is. This is going to be a constant battle. This is going to be a constant fight. Like you have to stay on the straight and narrow. I mean, you have to commit to, this is a lifestyle, and there are so many PCOS patients. If they, if you continue to focus on, healthy foods, low glycemic foods, and the lifestyle, as soon as I have patients who, as soon as they drink a can of Coke, okay, and they fell off the wagon. Insulin spikes, and you can always get back on the wagon, but these are things that you have to, day after day after day after day. And when you look at it from an obstetrical standpoint, okay, these women are more predisposed to gestational diabetes because of this predisposition towards higher insulin levels. Pregnancy, you can have normal insulin levels and be gestational diabetic, but you're more predisposed to gestational diabetes, which is going to lead to a higher risk for your offspring, okay, to have met their lifelong problems. So, how you take care of yourself pre-pregnant and while you're pregnant is actually going to carry over into your child's health. But this is all genes, and unfortunately, you can't change your genes, but you can change your lifestyle.
Got it. Okay. Okay, so this one is a little bit of a tough one. Miscarriages are caused by stress or lifting a heavy object?
Okay, so let's break this down. Okay, stress does not cause miscarriage.
Okay.
Okay, however, what happens is with miscarriage, and again, this is where my practice differs from regular OB practices, okay, is that we accept miscarriage as a normal thing. I mean, it happens a lot. It's very, very common, even though a lot of people think it's very, very common. And so you go to the OB, oh, I happened to get pregnant again. And oh, well, I was this or I was going through that. So the majority of miscarriages, okay, are their patients do not undergo an evaluation, or the miscarriage is too early for the evaluation. So again, the patient connects that I had this going on in my life, and that's why I lost the pregnancy. But you never tested the pregnancy. Most miscarriages are caused by bad eggs. It's just an abnormality. The egg came out with too many chromosomes. The pregnancy didn't have 46 chromosomes, 23 from egg, 23 from sperm. It had 47. It was just a bad egg. But because we don't prove that in all miscarriages, you get this association with, I did something. It had to be because I walked the dog, or I lifted the box, or I did this caused miscarriage. And because the etiology of the majority of miscarriages is not investigated, this is where this association comes from, okay? In the world, okay? We as subspecialists, every miscarriage that occurs in our office, like it's like the mega workup. I mean, we evaluate people upside down sideways for what causes this. And the majority of miscarriages that occur in our practice, I mean, some of them are unexplained. Some of them, I do say it. But the majority of them, we can say, all right, you miscarried because pregnancy had an extra chromosome 15. It had an extra chromosome 22. It was missing a chromosome. Like, this was a bad egg that got fertilized and implanted. So that's the vast majority of miscarriages. And then there's another bunch that have, autoimmune problems, blood problems, and the body attack the pregnancy. So because the etiology of miscarriage is not worked up, and it's not recommended to be worked up in the general population, you will, say, oh, this is what must have happened. I had a fight with my husband and I had a miscarriage. Like, this is where that comes from. In general, that is medically and scientifically proven. Okay. Now, as far as the lifting is concerned, so there are women out there, okay, who do have an incompetent cervix. So the cervix, which is the mouth of the womb, is weaker than it should be. Okay. I mean, and people have, I see it. I'm just like, their cervix is short and it's weak. And if you put extra stress on that cervix and you're doing too much activity, you could potentially, cause issues if you weren't aware that your cervix shouldn't, you shouldn't be doing those things. But that is definitely the outcome that is not the norm.
Got it.
So it's the reason that I encourage, the majority of my patients, when they come in and they have a miscarriage, let me do the testing. Let me figure this out.
Right.
The guilt that a woman feels after a miscarriage is enormous.
Right.
And even after you tell her, they still, are racked with guilt over this, which is why, as a physician, I want to try to eliminate this guilt. You did nothing wrong. There's nothing you did. This was something didn't form properly. This was just honestly bad luck. But because most physicians, we just say, all right, just try again. It just happened, and we don't go into why of it. We can associate this with, I must have been working too hard. I must have been doing this. I must have been doing that.
So just to follow up on that as well. So obviously the ones that keep having miscarriages, you can, yeah, you can, I'm sorry?
They need to see me.
Yes. So they need to see you, and it could be from the weak cervix, but there's also other solutions or reasons why it's happening because of bad eggs.
There's an enormous workup that we do. We look at genetic issues in the parents. We look at anomalies uterus, we look at fibroids in the uterus, we look at polyps in the uterus, we look at genetic predispositions towards thick blood, we look at immunologic things in the immune system that could be attacking the pregnancy. We look at, just chromosomal things that could have been in the pregnancy itself. So it's a very, very, very comprehensive evaluation. And there's a multitude of infection in the uterus. I mean, there's so many different things that are associated with it. And I would have to say 85% of the patients that I evaluate, I find a reason.
Okay, so then the next one is antibiotics, which we talked about a little bit earlier when we were discussing UTIs. Antibiotics can make birth control pills less effective.
There are certain medications that will cause antibiotics to decrease the efficacy of the pill. But your common antibiotics, your common antibiotics, whether the penicillins or the cephalosporins, they should not alter the efficacy of your birth control pill. Okay. Now, there are antibiotics that are used for tuberculosis. One which is called rifampin. Yes, that will screw up your liver. So I actually had a positive tuberculosis test when I was a fellow. So I was on rifampin for 6 months. And every month I had to get my liver enzymes strong. To make sure that the rifampin wasn't messing up my liver. And so the way steroid hormones are metabolized is through the liver. And so if you're taking a drug that is going to increase the metabolism in your liver, it's going to chew up that steroid hormone in the birth control pill faster, like rifampin, that can lower the efficacy of the estrogen and progestin that is suppressing your ovary.
Got it.
So it's not something that, we would say, you go to the dentist, they give you, a couple days of ampicillin to prevent an infection, say, oh, you need to use backup birth control. That is not something that has been proven. There are drugs though out there like seizure medicine. So if you're on seizure medicine, that's that your birth control is not going to work as well. Medicine. And so, birth control pills aren't the best thing for patients with a seizure disorder for birth control. So other methods that you should use. So there definitely are medications out there, but your common antibiotics, your common ones that are prescribed for, your little things, strep throat or, whatever, are not going to decrease the efficacy of the pill.
So your recommendation is anyone that is on birth control that are recommended to get on antibiotics for whatever level it could be, they should just consult with the doctor. Would this affect my birth control?
Correct. As long as you're continuing to take your birth control at the same time every day, when you take it in addition to the antibiotics, it should not decrease the efficacy of the birth control.
Got it. Okay, so while we're on the topic of birth control, not having a period due to birth control pills affects your fertility.
This is one of the craziest things that people think. What's the purpose of a period?
To go through the cycle, right?
But why? But why do women have periods? All a period is a failed pregnancy. That's it. That's all it is.
Yeah, so that means egg didn't get fertilized.
That's all. A period is a failed pregnancy. So basically, what happens? So in the beginning of the cycle, your body makes estrogen. The egg makes estrogen. The egg comes out. After the egg comes out, the body makes progesterone. What's the point of estrogen and progesterone? To make a bed for the baby. There is no baby.
Right.
The bed has to fall out. That's it. So unless you're trying to get pregnant, you don't need to have a period.
The
period is just for reproduction. The entire menstrual cycle is only for reproduction. That's it. That's it. So when you're on the birth control pill, what happens is the two hormones in the birth control pill are thinning the lining of the uterus. In general, there are different combinations of birth control pills. Some birth control pill will keep the uterine lining very, very thin. Some will thicken it up a little bit more. But if you're taking a pill that causes your lining of your uterus to be nice and thin, there's nothing to shed. There's nothing there was no bed there. There was no bed for the baby. So
Got
if
it.
you take birth control pills for 5 years and your periods get later and later and later and later and later, and then you stop the pill and for 5 days you don't get it, start taking the pill again. I mean, you didn't need to bleed because nothing built up. Now, there are different combinations of pills that will thicken your lining more than others. And every woman's body reacts differently to different pills.
Mm-hmm.
But in general, start pills in your early 20s, you know, and you're taking a continuous birth control, or combined birth control pill. You know, some women will even be off the pill for that week and just get a little spot or something like that. Not dangerous at all. Now,
Mm-hmm.
in general, my personal feeling is that why even be off the pill for a week? Like, there's just no point. Like, why would you even want to bleed? So I recommend to the vast majority of my patients is that if you're not ready to have a baby, just stay on your pill every day. Stay on your pill every day. Let's not get a period. Let's, you know, not get the cramps. Let's not get the mood swings. Let's not spend money on the tampons. I mean, I have both of my daughters on continuous birth control pills because I just don't see a need for it.
Mm-hmm.
You know, because my one kid was 16 and miserable, and we're on vacation and cramps and like moaning and crying, and you know, I said, you know, we're going for a bike ride this morning. Oh, I'm like, here, start taking some of mommy's pills. I'm like, I said, we will not be having periods anymore until you want to get pregnant. But then when you want to get pregnant, okay, within a week your fertility is back. Some people will. Some women will have maybe a 2 to 3 month, you know, delay in their periods, but I'd have to say 90% of women, as soon as they stop a continuous birth control pill, ovary wakes right up again and starts to work for you.
Mm-hmm.
So continuous birth control pills will lower your risk of ovarian cancer. It will lower your risk of endometrial cancer. Okay, I mean, it will lower your risk of endometriosis. Okay, it will make your quality of life so much better.
Right.
So, I mean, I am very passionate. However, having a menstrual cycle is ingrained in female culture from generation to generation from generation. And like, oh my gosh, I don't have a period, everything's building up in there. No, that's not the way it works.
Mm-hmm.
But the only reason, you know, that the menstrual cycle exists, I mean, think about it from, you know, thousands and thousands of years, is for reproduction. And every period you have is just a test. It failed. Like you didn't get pregnant that month because all that period was all that period is the baby's bed falling out.
So, last follow-up question on birth control. If you miss your pill one day, you don't take to the next, or you should?
No, you should.
You should.
Yeah, oh yeah, definitely you should. Because it all depends on where you were in the cycle. Okay, when you have a breakthrough ovulation. So the whole idea of the birth control is to make your brain think you have enough hormone. You're good. Like, the brain doesn't need to tell the ovary to make hormone. But if you miss your pill, your hormone drops, brain's like, we need estrogen.
Mm-hmm.
And the brain starts to send out a signal and it gets something rolling down in the ovary. Okay, there you get a breakthrough ovulation, you get pregnant. Okay? Normally you've got maybe a 12-hour overlap with missing the pill, but you want to try and double up on that pill to get your hormone level higher so that your brain and your ovary don't start talking. You don't want them to talk. They start talking again, you can ovulate right through that birth control pill.
Ooh, okay.
Mm-hmm.
Okay, well, you hear it here, guys. Go ahead and double up if you missed it.
Yeah, I mean, and again, using a backup method of birth control is also good for that month. Because you don't know when your brain and your ovaries start talking. I mean, if it senses a low hormone estrogen level, your brain's like, oh, need to get estrogen, and it starts to shout at that ovary, and your ovary's like, what's that say? You
Oh wow, okay. So we have two more. Myth 9. It is hard to get pregnant after 35.
Well, I'm a fertility specialist, so I only see patients who have difficulty getting pregnant. Okay, so what we have to remember is that 85% of the population is fertile. Okay?
Okay.
My world is 15% of the population.
Okay.
But what we do know is that my success rates, okay, are completely based on age. Okay? So whereas success with all the treatments that I offer my patients are pretty much equal up until age 35. We incrementally drop our success, which is say in vitro, our highest treatment. So, you know, a 30-year-old pretty much gets pregnant the same as a 34-year-old. I mean, not much difference there. But 35 and 37 drops 15%. Between 38 and 39 and 40 drops another 15%. And at 43, drops off the edge. Okay? So your egg supply is fixed. You are born with as many eggs as you're ever going to have. Okay? And they stay pretty steady in general up until age 34. But at 35, you see a steep decline, okay, in pregnancy success per month. And you see a steep increase in miscarriage rate because more of the eggs are unhealthy, because you're pulling from the bottom of the barrel. Okay,
right.
You're not pulling the young, healthy 22-year-old eggs. You ovulate the healthy stuff in your 20s, okay, and then you ovulate the kind of healthy stuff in your 30s, you know, and then you're scraping at the middle of the barrel by the time you're in your 40s. You're reaching at the bottom of the barrel and you're getting the crap. I mean, your miscarriage rate in your 40s can be up to 70%. When your miscarriage rate if you're 22 is 15%. Okay, and it's due to bad eggs. So if you are a woman and you are over the age of 35 and you have tried to get pregnant for 6 months and you have been unsuccessful, please see your OBGYN and get evaluated. See a fertility specialist, because you have no idea. That is what I do day in and day out. I fight age. Age. Age is the biggest factor. And say you're 35 and you don't want to get pregnant. Great, okay? You don't want to get pregnant? Wonderful. You want to put it off? Let me freeze your eggs. Freeze your eggs. Let me put 15, 20, 35-year-old eggs in the freezer for you. I can help you get pregnant when you're 50. If you got 35, but I can't help you at 50 to get pregnant.
Right.
So where we want to catch women is we want to freeze their eggs before the age of 35 if they're not interested in pregnancy, or we want to evaluate them within 6 months so that this will make their journey to baby much more efficient. You know, you see somebody, they're 40. How long have you been trying? 5 years. Why have you been trying 5 years? Like 6 months is your window. If you're not pregnant and you're over 35 months, please seek help. I mean, because we can help you. But if you wait too long, again, I can't get blood from a stone. If you show up in my office and the eggs are gone, the eggs are gone.
Right.
If you froze them, I can use them at any time. I mean, I can use 34-year-old eggs when you're 45, and you know, and your uterus can be healthy, but these 34-year-old eggs and we're 45, I can't help you. So it can become more difficult to get pregnant at 35. There are certain tests out there that some OBGYNs are drawing and some aren't, but it's a test called anti-Mullerian hormone. And anti-Mullerian hormone is going to be a snapshot of how many eggs you have compared to somebody else your same age. And so maybe you're at risk. Okay. One question here. Thank you so much for information. Quick question. Is it safe to stop mesylate progesterone estradiol when you're 11 weeks pregnant? Absolutely. Your placenta really starts to take over at 8 weeks. We continue all of our patients on 12 weeks. Our IVF patients, we wean their levels. Okay. But in general, if you're not an IVF patient and you're taking supplemental estrogen and progesterone, your placenta should be good by the 10 weeks. I mean, probably 10 weeks you're good, but again, a little overkill just because of what we do. So again, just that question since it quickly came up.
Absolutely. No, I was going to read it to you as well. Okay, so that's awesome. So the 10th myth that we have on our list tonight is women's libido decreases as they get older.
Again, we're talking hormones again. Okay? So we're talking hormones. So your ovary, again, when it's younger, it's making a lot more hormone. As you get older, the hormone levels start to get lower. They start to wane. And so the hormone that will be the one that, you know, is control of a lot of people's libido is going to be testosterone. Okay. And testosterone levels, again, are going to kind of wane as you get older, which is, you know, all the rage as women are, you know, getting their, you know, menopausal, you know, testosterone creams and pellets and things like that. And that can help libido. So yes, it's not because of the age, it's because of the effects of age. It's like wrinkles and gray hair.
Got it.
I mean, so your hormones will play a significant part in a woman's libido. Okay. I mean, there's so many other factors. I mean, there's stress and, I mean, there's so many other factors involved, but, when we're talking from a fundamental standpoint, when you start to replace these hormones that were, not at the levels where they used to be when someone was younger, you will see a difference in how a woman feels. And it may not even be libido. Like if you're lacking estrogen, extra estrogen make you feel better. In general, a sense of well-being, a sense of feeling better, just like PMS, you're lacking progesterone. A sense of having these, hormones that you used to have and you no longer have will try to maintain that sense of well-being. So it's the same thing with testosterone. Again, just women don't need very much. I mean, just at times that a patient needs, but even just replace estrogen, because so you're lacking estrogen. Well, how does your vagina feel without estrogen? Okay, it's dry and rough. And it's when you look at a vagina, it's pale. It's not pink and moist, and it's lacking estrogen. So where would you stand as far as libido? So it's not all testosterone. But it is that lowering level of hormones that occurs as we age because our ovary is aging. So it's not because you're older, it's because your hormone levels are lower, and because you're lower because you're older.
So I think one of the biggest things that I took away from all of the myths that we discussed today is that what we are typically thinking is a lot of association, and we tend to make that the root cause, but really it's just a correlation to what the root cause truly is. And
Correct.
That's how we debunked a lot of the myths that we talked about today. Is that right?
Because you just start to think, well, this caused this, and it's like, well, kind of, but not really.
Right. Okay, I think that was definitely something that I took away from this. We debunked a lot of myths today, and I know that the people that chimed in today really appreciated all of the information. And one of the things that I appreciated so much about you is the way that you broke it down and did all these associations with the soldiers and the armies around the ovaries. Like, that makes it so digestible for people that don't have the degree and the experience, and they're just trying to understand. And I know you do this every day, so you've probably found ways to make that conversation way more relatable so that they could understand what's happening with their bodies.
I mean, I think it helps if the patient understands the condition, or the patient understands the underlying cause and what we're trying to do to help it. Because there's not just one thing to use to help it. So, but kind of understanding what's going on with your body, because I mean, I have ultrasound machines, I have bloods, people are just almost like, what is going on with me? Like, this is the way I feel, and I understand why I feel this way. I don't understand why this is happening to me. And then we're able to, kind of look at different hormonal panels, different patterns, and we say, this is what's happening. And then I say, these are your options. We can try this, we can try this, we can try this, we can try this. And we have two different pathways. We have the pregnancy pathway, and then they have the feel better pathway. And some of them are completely in two different directions. But trying to break it down as to what is actually going on with a woman's body that's causing how she's feeling helps us treat her.
Absolutely. Well, I want to thank you so much again, Dr. Wood. I don't know if you have any other closing remarks that you want to tell to any of the listeners. This is something that will definitely be posted on our NACA South page so that it could be a reference to anyone that wants to see this video. But if you have any closing remarks, I definitely want to invite you to say a few things before we end our amazing live session that we just had.
All right. Well, again, thank you so much for inviting me. Again, as you can tell, I'm very passionate about what I do. I'm on the IVFMD platform tonight. Again, I discussed our practice initially. I also have my own Instagram at Dr. Ellen Wood. Again, my whole thing is, again, I'm a fertility physician, but what I do all day is I celebrate the successes that we have. I try to motivate patients who are struggling to get pregnant. And one of my big things is I try to educate. And I think education in healthcare is one of the most important things, because there is so much misinformation